that. You know, when I do workshops of this type, I always start off wanting to know who my audience is, because if I know who my audience is, then some of the things may be more relevant to our discussion than not. So the group is not that big, and I won't go around through everybody because it will take a lot of time, but maybe just have a show of hands. How many in the audience are physicians of any type? Okay. Are neurologists, physiatrists? Pardon me? Psychiatrists. Physiatrists. Any neurologists? Okay. How many nurses, if any, in the audience? Okay. Psychologists of any type? Okay. Fine. Occupational therapists? Speech pathologists? And physical therapists? Any physical therapists? Vocational rehabilitation specialists or counselors of any type? Okay. Are there any parents of people who have brain injury in the audience? Are there any people in the audience who have suffered a brain injury? Okay. Thank you. There are a number of topics that I was going to cover. I was going to give you an historical view because I like history about understanding things. I don't think you really know what's happening now that's really new if you don't know what happened in the past. And many times we simply repeat with new terminology what people had thought about years before us. So I think it's important to really understand history, but it takes a while to develop the historical context. And because I will only have about an hour to an hour and a half with you, I'm going to make that brief. And then I'm going to talk more about some data that has emerged on the impact of impaired self-awareness on the process and outcome of rehabilitation following stroke and traumatic brain injury. If we had time, and this is the most time-consuming aspect of it, there's a whole series of studies emanating from the neurosciences that help us separate out what might be going on in denial, that is, what are the brain correlates of denial as a defense mechanism versus what's going on in terms of anosognosia and impaired self-awareness. That takes a little time to develop those ideas. We'll see how much time I have, but if I can get to that, that's what I would like to do. Now here I'm going to put you on the spot. You came here to hear these presentations. We are your consultants in many ways. We're here to give you our thoughts, but we want to know what's of interest to you. Are there any particular questions that anybody in the audience had that they were hoping would be addressed in this particular section, or you just wanted me to say what I wanted to say? In other words, sometimes people come to a meeting and they want to know how a certain aspect of the topic relates to their clinical practice or to their research. So the question I want to pose is, for the audience, is there any particular question or questions you hope that I would address? Do you understand what I'm saying? Okay, you understand. Yeah, please.
I'm working at a rehabilitation center for children with CD, cerebral palsy. Would you think that what you said this morning about anosognosia could be applied to this population?
It's a really interesting question. You don't see much literature on anosognosia in children. However, as I will talk about today, there are 2 case studies of Anton syndrome in children, which makes an argument that you can have disturbances of awareness in that developing brain. There's a lot that we would debate about of what should an 8-year-old be aware of as it relates to themselves, or a 12-year-old, or a 6-year-old. Because there is not a good normal psychology of awareness in the normal developing child, it's somewhat problematic to automatically convert these ideas. But I will say that my own belief is anytime you damage the brain, at some level you affect awareness of a function. Even the case that Barbara Wilson gave of the knife in the back of the head, it was quite interesting to me. The patient, as I understood you describing it, Barbara, didn't know she was injured. She felt up there and discovered it. But when the brain is affected, it does not know it's affected. Now, we learn because we have overlapping systems of the brain that will give us information, there's a problem here. But the nature of a brain injury is to actually disturb consciousness at some level. So I wish I could tell you more about that. I'll tell you some of my thoughts about it as we get into it. We've tried to develop a little questionnaire called the Children's Daily Functioning Scale, where we have children answer yes or no questions, but it's not a forced choice thing. We ask the question, do you remember to brush your teeth at night before going to bed without your parents reminding you? The child says yes or no. We ask the parents independently, yes or no. Some kids will look at us and say, maybe, that's okay, or sometimes. We take whatever they say, and then we've been comparing the parent's view from the child's view. And what we find preliminary is that around 6 or 7 years old, the few normal kids we've studied have about a 50% concordance with the parents, okay? And then as you go up to about 12 years old, right before the adolescent years really hit, you get about a 70 to 80% concordance. With brain injury at different levels, we find the concordance hovering around 40% in children that have severe injuries. I should say, emphasize this. But these are acquired injuries. These are not developmental problems. But I hope that this kind of discussion will stimulate people to start thinking creatively about measuring awareness in children that have developmental brain disorders. Okay? Any other questions? Please.
What I hope to get out of your talk today is that when I walk out of this room today, I want to feel that I have a couple more ideas in my mind to try Monday morning with my patients that they do not understand their injuries because of PI and something like that.
You know, again, I heard the first part of that.
I'll try to speak louder.
Okay.
I want to feel out after your talk that I have a couple more ideas in my mind that I could try Monday morning with the patient with PI.
Okay. So you're saying you hope that as a result of this workshop, when you start work on Monday morning, you'll have a better understanding of not only understanding the phenomena, but doing something with it, that is, working with it from a rehabilitation point of view? Okay. Well, that's a very important topic, and I will make sure that I emphasize this. My colleague and I, Janine Marone-Stupinski, we just finished writing one chapter in a book that we're editing on this topic, and we have some specific ideas to apply for traumatic brain injury, a few for stroke, and a few for dementing conditions. But I promise you I'll give you my thoughts about that before we end. I hope that what I have to say will help clarify from a diagnostic point of view what you look for, but translating that into rehabilitation is always a challenge. It's in a way like aphasia. There are different ways of conceptualizing aphasia. Some are very practical in terms of clarifying the behavioral problems. It doesn't automatically lead to a clear understanding of what to do. And Barbara Wilson gave a very good talk on that earlier, that we can have all kinds of interesting diagnostic information. It doesn't always tell you what to do. However, if what I had to say this morning has any clinical relevance, the notion that if a function is diffusely represented in the brain, the less diffuse the brain injury, the more capacity to use the residual abilities to gain awareness. And I think this helps explain why some people do gain surprisingly good awareness with times and others not. Now, can you do something to actually clinically increase awareness? Some of my colleagues will say absolutely yes. Some of my colleagues will say absolutely no. That is very hard to shift it. And I haven't seen any definitive paper emerge to answer that question. But I do know it's hard to change. What I think happens many times is you build a relationship with the patient, they trust you, and then you can guide them. They do not always see or experience the problem the way you do. But if you form a good working relationship because you understand what this impaired awareness or denial of difficulties are, if you understand it, often you can convey it in a way to the patient that makes sense to them. They will then follow your lead. But I will give you a few examples towards the end. Any other questions that you were hoping I would address? Please.
What are the expectations of your patients coming to you? Obviously, they have some problems with anosognosia, so they are not aware of their problems. So they could not have come to you asking for treating this area.
Okay.
What they are asking for.
Well, your question actually stimulates two thoughts, which is often my problem in life. I have more than one thought going at a single time. But when we started working with patients who were young adult traumatic brain injured patients that were 2 years after the injury, they were unhappy with life. They were not working. As I mentioned earlier, they did not have a relationship. They were not driving a car. So they wanted help to do whatever they had to do to get those things again. But they did not spontaneously come in and say, I'm unaware of my problems, can you help me? or they did not spontaneously come in and say, my memory, they might say my memory is bad, it does affect me somewhat, but I don't think that's not my biggest problem. My biggest problem is people know I have a brain injury and they're biased against me now, or they don't give me a fair chance. Or as one patient said to me, I have no credibility anymore after my brain injury. Every time I do something, somebody points and says, that's due to your brain injury. So that my sense of confidence in my own judgment has been eroded. So people will come in with many problems in everyday life, but they don't know what the underlying cause of that problem is, at least the ones that came to us early in our day treatment program. I wrote a book 10 years ago that needs to be revised, but I said the first principle of neuropsychological rehabilitation is to reduce the frustration and the confusion in the patient so you can adequately engage them in the rehabilitation process. My experience is if you understand what it's like for them to have that brain injury, you then modify your assessment procedures or your rehabilitation procedures to have the patient begin to observe, what's wrong with me? Why am I having this difficulty? Once they start to be a partner with you of trying to figure out what's wrong, then you're on the right road. But if you do tasks that only frustrate the patient even more, or even add to their confusion about why am I doing this silly task? I did this when I was 8 years old. I don't need to do this now when I'm 48 years old. If you add to their frustration or confusion, the ball game is over. You've lost them. So a key aspect is to enter the patient's phenomenological state, sense what do they experience, and then use all of the knowledge you have from any area, from psychoanalysis, from behavioral therapy, to neuropsychology, to philosophy, to whatever knowledge base you have. How do I reduce the confusion in this patient's mind as to what's wrong? Okay. Once you do that, you're in the right road. And I just found over the years, the more I've thought about the awareness problem, maybe it's an illusion, but I felt I got better in understanding what that they were experiencing. I had a better sense, is this really an underlying neurological unawareness, or is this a mixture where they have some awareness, but it's very painful for them to deal with what it is that they have to deal with? So I'm not sure I answered that question, but that's the first thought. The second thought, years ago, I went to London, and I was giving one of my first talks in London, and I was very much influenced by Carl Jung's ideas. Because Jung was interested in psychotherapy in the second half of life. What happened when you're 40 to 50 years of age? What are the issues you deal with? They're different than when you're 20, 25, 30. And I had an aunt who was a physician who knew that I was interested in this, and she gave me a book to read, and I put it in my suitcase on the plane. And it was a book by Susan Bach, who was a Jungian analyst that lived in London. And the title of the book was Spontaneous Drawings of Severely Ill Children. And I was reading this book on the plane, and I was fascinated by how she had taken some of Jung's ideas and applied it to understanding children that had leukemia and that were dying from leukemia, and how the drawings of the children revealed a lot about the child's psychological state and what they knew about their own illness, which was rather surprising. But to make a long story short, as I'm reading this book, it says Susan Bach, consultant psychotherapist, London, England, and I'm on a plane to London, England. So when I got there, I called her, and I got this very dramatic voice on the phone, hello? And I said, I told her who I was, and could I talk with her? She says, send me a letter. I'm in London, and I'm writing her a letter. She says, send me a letter. If I have a cancellation, I might see you. She says, but I very seldom get a cancellation. So I wrote the letter. Son of a gun, 3 days later, I get a phone call in the hotel. She says, hello? Hello. She says, you're a very lucky man. She said, I had a cancellation. Come to my house in Golders Green, 1 o'clock, Tuesday afternoon. So knowing that she was an analyst, I couldn't be too early and I couldn't be too late. I had to be right on the time. So I got there truly an hour early. I walked around the block several times. I found her house. I went to a church and prayed a little bit. I walked around the house some more. And I went to see her right at 1 o'clock. The door opened up. This little tiny lady who had the most piercing blue eyes I've ever seen in my life, an extremely intelligent being. She opened the door. She greeted me. We sat down. We began talking. There was many interesting discussions. But in the context, I told her I was interested in consciousness and awareness and understanding psychoanalytic and analytic psychology concepts as well as neuropsychology. She then looked me in the eye and she said, "Do you ever bother to ask your patients if they want to be aware?" Now, this is a classic analytic idea. And being younger and impetuous, I said, there's no choice. If you're going to get them back to work, they have to be aware. But she calmed me down with that comment. It made me recognize not all patients are eager to become aware. It's a difficult process. And this is where I go back to, you have to be a good clinical psychologist as well as a neuropsychologist to work with these patients. No matter what your training is, your basic instincts has to be of a clinical psychologist and a neuropsychologist. So a truncated statement is, I'm always interested in the awareness problem. I try to go slowly to figure out what is most frustrating to the patient and how to help them work with me to figure out what's the problem. If we have that working relationship, we're on the right track. If we don't have that working relationship, we're not on the right track. Okay? Kind of a long-winded statement, but it gives you a little bit of ideas. Any other questions of what you were hoping we would address? All right. Well, I alluded to this earlier, and I will go through this rather briefly, but it is an important set of introductory comments. As I mentioned this morning, there is no comprehensive model of human consciousness and how it emerges from brain function, and therefore it's very, very difficult to conceptualize, categorize the various disturbances that we have. It remains elusive. We know what unconsciousness is by a failure to respond. We do not know what consciousness is at all. At all. And it's an amazing thing. We know that the brainstem structures and the thalamus must play a key role, but what actually allows this biology to produce human consciousness? It is the most fascinating question that we could ever think of, the most fascinating. How from this biology does awareness emerge? Does a plant have awareness? We know animals have some form of awareness, and as they go up the phylogenetic scale, the awareness seems to increase. But what exactly is this? And how does it emerge? We do not know. The other thing that we do know is that disturbances of self-awareness change with time. They're not static, just like aphasia changes with time. You have an acute stroke, you can be globally aphasic. And then as time goes on, you have more of a Wernicke or comprehension type of aphasia. You still have disturbed fluency, but you improve. And in people who really do very well, with time they may only have anomic difficulties, or if they have very specific lesions, they may have reading problems. But any experienced speech pathologist will tell you, if a person had a really significant aphasic disturbance after traumatic brain injury, 10 years later, you give them a narrative to read that has an ambiguous sentence, and you ask them, what does this sentence refer to? And they struggle. There's always a residual of aphasia. When you disturb consciousness, there is always a residual. You must have to look for it carefully. You may have to develop better techniques for it, but it's there. That's the nature of how the brain is, and this adds confusion because it changes. It adds confusion as to what is the actual etiology. The separation of denial as a method of coping, and we'll talk a little bit, I'll give you a little bit more formal definition of denial later, but in essence, it's a negation of reality. No, this is not true when we know it's true. Years ago, I was given word of a childhood friend that was killed, and I remember the first words out of my mouth were, no. It reflects it. I don't want to face that reality. No. It's a reflex. Denial as a defense mechanism is not something you do with volition. It is something you do for protection. And it can persist for years, depending on the nature of the wound or the insult to you personally. This is different from unawareness, where the brain does not experience the problem. Early in our rehabilitation, we would use an analogy. When the kidney is hurt, it tells the brain. When the brain is hurt, who does it tell? The nature of the brain disorder is that highest level of the highest level of integrative brain activity is human consciousness. So when the brain is affected, it doesn't know it's affected. Again, it can discover it later, but it doesn't know it immediately. Self-awareness is, of course, a personal, subjective, phenomenological state, and therefore we are always measuring it indirectly. We have no measure of your awareness or my awareness. This is one of the reasons why the neuroscientists have stayed away from the problem, because it's very difficult to get your hands on this and to reliably measure and manipulate this variable in order to see what the mechanisms are that underlie it. So we always have to be humbled by the fact that awareness is measured indirectly, never directly. Now, the beginning and concluding observations. There are residuals from these frank anosognosia or loss of consciousness that do impact the patient's recovery. Make no doubt about it. Sometimes people will say to me, can you have persistent unawareness and have a good outcome? If you have people who you trust and who guide you, yes. But if you don't have people who you trust and guide you, no. You're going to make one miserable mistake after the next because you do not sense really what's wrong. But the goal, therefore, and from my point of view, is to constantly help them have an understanding of what's wrong. Many people raised in the past, this will only depress the patient. If they know what's wrong, they will simply get down or sad. This is nonsense. If they have denial, yes, they will have an emotional reaction. But if you're anything close to a decent therapist, you don't force denial. Nobody can force denial out of existence. The patient, as they become progressively aware of things that they have denied, will go through a period of remorse or sadness. But when they really understand how they've been affected, there's often a relief. They have a clarity now of what's actually wrong. And now they deal with the normal human suffering of this. We'll talk about that tomorrow in psychotherapy. But it does impact the process and outcome of rehab. These deficits are not detected by our traditional neuropsychological methods. And that's one of the reasons it's been confusing to us. If we had a clear dose-response relationship between a certain kind of neuropsychological test and various neurological variables, then we would feel more confident in knowing exactly what we're measuring, and is it changing with therapy or is it not changing with therapy? How does it relate to a variety of location and severity types of injuries? As I mentioned earlier, we continue to get what I will call glimmers or brief insights as to the possible mechanisms responsible for anosognosia, and it is a fascinating story. And it's interesting to read the new science, articles coming out of the various neuroscientists where they're giving us closer and closer approximations of what might be going on, but we still have limited knowledge in this area. But the little knowledge that we do have does have implications for how we rehabilitate people and certainly how we work with them in psychotherapy. So the original goal of this workshop, which will now be truncated, was to review selected findings, old and new ones, that are relevant to the topic of anosognosia, place these findings into a clinically relevant context, describe evolving models, and again the emphasis is on S, models, that help explain these phenomena, and then demonstrate that anosognosia is indeed impact the process and outcome. Again, I'm going to truncate this because of the time. I've already apologized for not properly defining anosognosia. This is McDonald Critchley. Barbara showed us a picture of him earlier. It is a lack of awareness of a disease state. Critchley, in his book on the parietal lobes, which I have a copy, by the way, Barbara, I bought many years ago. I will not let it out of my sight. It's one of the best books. I've often waited to have somebody do another book on the parietal lobe. A lot has been learned since Critchley's time. It's not appeared. It's one of the best scholarly books that you can possibly get your hands on. I'd like to see one done on the temporal lobes and on the occipital. I'd like to see one done on the insular cortex, because the insular cortex is going to become a new area of information for us as it relates to the conscious representation of a subjective feeling state. But Critchley cites Babinski. And Babinski reported actually on 2 patients, and the patient was unaware of, or seemed to be unaware of, that was Babinski's terminology, of the existence of the paralysis for which they were afflicted. In the second paper on the subject, Babinski drew attention to 2 clinical points, and we see this every day in rehab centers throughout the world. Both patients had sensory impairment down the affected side. Hemisensory loss is very, very common, and both had left-sided involvement. Could it be, Babinski wrote, that anosognosia is peculiar to lesions of the right hemisphere? Well, the right hemisphere plays a very, very important role in human self-awareness, and lesions to the right hemisphere will often produce some disturbance, but it is not simply localized in the right hemisphere. There's an interesting case presentation done by Sandiford, which actually McDonald Critchley cites in his book. Because of the time, well, I'll go through it a little bit. This is a kind of a classic example. He says to the patient, how many of you seen anosognosia for hemiplegia? Maybe I could say, how many have actually seen patients? Okay, not too many, a few. So what happens? The patient has a right hemisphere stroke. I won't read this over, but I'll just tell you what happens. They have a right hemisphere stroke. They're sitting in, I can remember the first one I saw in Oklahoma City with a man named Dr. Carpenter, who was a neurologist. He goes into this lady, very nice lady from an affluent area in Oklahoma City, and he says, Mrs. Jones, how are you today? She says, fine. And her head is slightly turned away from the left. It's fine. He's here, but her head is slightly turned. He says to her, Mrs. Jones, is there anything wrong with your two hands? Not that I'm aware of. That's classic. They don't say no. They say not that I'm aware of. They imply, there's an implication that they may sense something. Then he says, Mrs. Jones, raise your hands for me. Mrs. Jones, how about your other hand? She turns her head slightly away, like she's even ignoring what he's saying. Mrs. Jones, how about your other hand? What about it, doctor? Is there anything wrong with it? Sometimes no response. Sometimes, again, I don't know. He takes the affected hand, and he puts it in the good visual field, and he says to her, is this your hand? Very interesting. She says, I don't think so. Whose hand is it? She pauses, some perplexity. It's your hand, doctor. No, it's not my hand. Look, my hand is so much bigger than your hand. Again, no quick acknowledgement that this is in fact the case. In this case of Sandiford, there's a part where he finally convinces her, and she says, I guess you're right. And then later the doctor says, whose ring is this on your hand? She can identify her wedding ring. So she says, he moves the hand and says, whose ring is this? And she says, doctor, you have my ring on your hand. And this got people really fascinated. Look at all of the symptoms that are associated with this. It's not just that the arm doesn't work. There's a lack of attention to detail. There's a logic that explains away. There's an uncertainty. This is what attracted people to this. Isn't this one of the most amazing phenomena you ever see? It changes rather quickly in some patients. Not all, but it's not uncommon. Within 30 days, it's gone. And it looks gone. If you test carefully, it's not totally gone. But people thought, well, this was just an unusual phenomena that affects mainly the motor system. It is not such an unusual phenomena. As I mentioned earlier, Anton also described it for blindness, and he described it for hearing loss as well. Biziak and Giamonti were the first to demonstrate that in a single patient, you could have a hemianopsia, homonymous hemianopsia, partial visual field loss, and be aware of it and not your hemiplegia, and vice versa. They could be aware of the hemiplegia, but not their visual loss. There are some patients who continue to report that they can see perfectly well after the hemianopsia is demonstrated, but there are very few. Most of them it can be demonstrated that they do have a problem with vision, but they seem to, quote, forget it. They don't seem to attend to the problem, so they're bumping into objects all of the time. But if you do ask them, is there something wrong with your vision, most of the time, 1 month, 2 months later, they'll say, yes, there is. There are a number of early studies on aphasia that showed the anosognosia. I can remember one young man that I saw who had traumatic brain injury. We'll talk about him in psychotherapy tomorrow. He was fluently aphasic. We taped his aphasia during his early rehabilitation course. And when it was all over and he regained a lot of his language function, I asked him, do you remember ever a time where you could not speak properly? And he looked at me and said, no. And then I played him his voice, and LeBrun has done the same kind of thing. He was shocked. God, that's my voice. I'm making no sense. He says, it's funny you asked me. I remember talking to people, and they looked at me with a weird look on their face. They didn't understand me, rather than I didn't make sense to them. You see this over and over again. The problem is always explained exterior to the self. It's the nature of how the brain attempts to explain a lack of awareness of a severe function. And aphasia certainly is the case. There are a few cases of hearing loss, a very interesting case in the literature. A lady has a tumor in the right thalamus, and she complains there's something wrong with her stereo. It's the old days when the stereos, we had the dual speakers. She could not believe she had trouble with hearing. We know memory disorders are commonly either not appreciated or diminished. The elderly patient who's 65, 70, who has early signs of dementia, says, of course I have a little trouble with my memory. You would too at 65. It's a part of the normal aging process. I can remember what I want to. What's there to remember? You know, I don't go to work. My children don't visit me anymore. What's there to remember? They will explain it away. We were impressed in working with traumatic brain injury patients, that I gave you the example this morning, huge problems of social judgment. You're being too critical. You're too old. You don't understand. I was just being friendly. They don't get it. They don't see that there's a problem. And also in movement disorders. In Parkinsonian disorders, for example, it's seldom reported, but we have a research project right now on this topic, and we are showing that there is about 30 to 40% of patients in the mid stages of Parkinson's disease that are not aware of their motor limitations. In Huntington's chorea, they become quite aware, but you know, it's a dementing condition. So this is not unique to one class. Anosognosia has been seen since the time of antiquity. It was not discovered by neurologists. It was there for a long time before, and there's some interesting quotes about this. It can also be present in neurosurgeons and neurologists who suffer brain injuries, and psychiatrists. There's a guy named Labaugh who wrote a paper called Denial Inside and Out. He was a psychiatrist that had a traumatic brain injury. He describes his lack of awareness and when people told him he could not see patients in the hospital and how he reacted. This is a quote from Eduardo Biziak's paper from Antiquity. You know that Harpastes, my wife's fatuous companion, has remained in my home as an inherited burden. This foolish woman has suddenly lost her sight. Incredible as it might appear, what I'm going to tell you is true. She does not know she is blind. Therefore, again and again, she asks her guardian to take her elsewhere. She claims my house is dark. Brian Kolb, noted neuropsychologist and neuroscientist, suffered a left occipital stroke. You should read about it. It's a very interesting paper. And Brian talked to me about this. He said he suffered from migraines. He went to bed one night with a migraine, woke up, flipped the light on in the room, and he says, something wrong with the light bulb. I got to change it. And then he went to pour himself tea, since he's British and not drinks coffee, and he couldn't find the cup. He's poured it on the floor. And being the scientist that he is, he immediately took out his pen and he tested his own visual fields. And he discovered, I have a visual field loss. He discovered it, then he knew it. But he did not wake up and say, I'm blind in one half field. He did not. It's not the way the brain works. He had to discover this. We see this in antiquity. Von Monaco was one of the first to describe this, a Russian who was the first professor of neurology at the University of Zurich. His patients had amnestic disorders and confabulation. This is another very interesting history. If the patient confabulates, the arm is not mine, it's your arm. Is this a different syndrome than when there is not confabulation? We now refer to this as somatophrenia. But von Monaco really pointed this out in 1885. His studies were discounted. Anton showed it with focal lesions of the brain. Babinski, young Babinski, old Babinski, talked about this again as relates to hemiplegia. Charcot also was interested in this phenomena. This was his patient, reportedly, and this is supposed to be an hysterical limb. It looks rather real to me, the way it's turned upward. But in any event, he reportedly hypnotized this patient, and the motor functions returned back to normal. He got involved in a whole line of theorizing based on Freudian ideas, or I should say, Freud developed his ideas based on Charcot's observation, that something to do with suggestion, something to do with emotional trauma, could produce physical types of symptoms. And someone whose work I really found very helpful to me early, because it was the only person I could read that talked about these problems, was Ed Weinstein. Ed has subsequently passed away. But in his very influential book with Bob Kahn, he wrote, the various forms of anosognosia are not discrete entities that can be localized in different areas of the brain. Whether a lesion involves the frontal or parietal lobe determines the disability that may be denied, not the mechanism of denial. Before Ed died, we had a chance to work together, and he said, George, if I could retract anything, I would retract that sentence. He did believe, before he passed away, that in very specific areas of the brain you could have very specific forms of denial. But early in his work, he had to change it. And as I've been studying this, I'm going to be changing some of my earlier thoughts, too, about the mechanisms. But that's another story. Pardon me?
As long as you don't publish them.
Well, you have to publish them. I mean, once we make a mistake, you got to write it and say we made a mistake. But actually, that's not so bad. I was talking with Pierre North earlier about you get to a certain point and you're not so much bothered by your mistakes. You find them interesting and you learn from them, and so it's not as threatening perhaps as when we were earlier in our career. William German was a neurosurgeon who wrote a very interesting paper about his own anosognosia for right-sided hemineglect. It's a very rare case. He was in Disneyland in Los Angeles, was on the Matterhorn ride, the roller coaster ride, with his grandson. He's coming around the bend quickly, and he feels a thud or a pressure in his skull, and he says to himself, wouldn't it be funny if I developed a subdural hematoma on this ride? And he gets off, he's tired, goes back to the motel and tells his wife he wants to lay down, does this, and he describes how he becomes forgetful of various things. And then what's very interesting, when he gets back to Yale, where he was teaching surgeons how to operate on patients, he said he remembered that he forgot to take the right foot into bed. He even had the impression that the right side of the car took up too much room on the road and needed particular care and steering. The problem is exterior. The foot forgets to come in. The car has too much space. He's a neurosurgeon. He's probably seen this thousands of times. But when it happens to you, you don't know. You're not aware of it. So Biziak made a very important couple of comments. He said, a satisfactory definition of anosognosia per se is perhaps impossible, attributable to the fact that the term anosognosia, rather than referring to a truly distinct symptom, may be, and has indeed been, used to denote aspects of patients' behavior in relationship to their illness that are heterogeneous in appearance and unlikely to depend on a specific set of causes. He also goes on, I won't take the time, he also goes on to make a point that rings true to me every time we try to study this. He says, anosognosia deserves assessment tailored to each individual case, compromising faithful records of all the relevant spontaneous behavior, not just the ones you're interested in testing your hypothesis, all of what the patient does, as well as that instigated by the examiner's queries, the limits to which are only set by the examiner's inventiveness and the patient's mood and intelligence. In other words, how smart are you and how smart are the patient, how cooperative is the patient. That determines how you actually assess this. Now, our own model for doing this is to look at anosognosia from different perspectives. After traumatic brain injury, with severe injuries, they tend to improve. I mean, period of post-traumatic amnesia is a form, it's just clearly a disturbance of consciousness. It clearly is. And the person often they don't know why they're in the hospital. They say, I had a baby, that's why I'm here in the hospital. It's not because I had a brain injury. But it gets better. So you can follow what are the correlates of anosognosia after TBI, how does it get better? In dementias, it goes in the other direction. It's getting worse with the passage of time. The problem is in these conditions, these are diffuse injuries to multiple areas of the brain, and you cannot meaningfully assess specific, discrete forms of anosognosia. Stroke patients are the best for that. So we are looking at this from overlapping models, so to speak, looking at focal forms of anosognosia versus anosognosia for neuropsychological functions that must relate to multiple brain areas, not just to one type. This is where it's a choice point, because I can't go into this as much as I like, but I'm going to skip ahead past the neuropathology, past our early assessment, past the finger tapping, although I want to point out that we've been able to replicate the finger tapping in Japanese patients as well as in American patients, past what I mentioned earlier, past this, but I'm going to talk about this. Sterling Johnson is a very talented young man who was with us for, unfortunately, a brief period of time and then went to the University of Wisconsin. I was dying to know what happens in the brain when you do the Halsted finger tapping test. So Sterling devised an experiment where we took the Halsted apparatus and we taped it to the patient's leg, and we laid him in an MRI scanner. This apparatus has metal in it, so it's going to heat up in a scanner because it's, of course, magnetized. And he had to modify the, the regular testing procedure is 10 taps in 10 seconds, US, 10 taps, 10 seconds, and so forth. He did 15-second blocks in order to pick up changes in oxygenation of the brain and the utilization. So it's not a perfect parallel, but it is at least the apparatus that we use clinically. And the first thing he found was the main effect, that when I do this, my ipsilateral cerebellum activates and my contralateral motor strip activates. There's hundreds of studies that show this, but not with the Halsted finger tapping test. He also showed that in group data, first of all, there were individual differences. That's one of the problems with the functional MRI and so forth. You see summaries of data after a lot of statistical massaging of the data, but there's a lot of individual differences in people in terms of how we carry out these tasks. One of the things he found, though, as a group was that their tendency to be supplementary motor cortex tend to be activated, and in a few patients, the ipsilateral sensory motor strip was also activated. But then Sterling asked a very interesting question, and it relates to the question of fatigue after brain injury. If you tap on my tapper for 3 trials, you're going to be tired. And so I normally give you a break, and I do it on the other hand. He asked the question, what's different in the activation pattern when you start the tapping task versus at the end when you're tired? What are the correlates of the fatigue when you have to continue to press? And what he showed was in these areas. And this is summarized over a number of individuals. The point is there's activation not only in the sensory motor area, dorsal frontal, there are areas of the temporal that activate, and they are bilateral in nature. That was one of the big lessons, that this unilateral task is not done just by one side of the brain. It's done by both sides of the brain. That helped us explain somewhat that diffuse lesions would impact the speed of finger tapping. That's why it was a correlate to the unawareness problem. And if you take the green main effect in the others, that's what you see. Now, with dementia of the Alzheimer's type, I already mentioned Stanley Appel, a very insightful neurologist, and I heard him give this talk, and I wrote it down immediately when he said it because it's true. He said, in dementia of the Alzheimer's type, first the patient knows and the family doesn't know. As the disease progresses, the patient and the family now both know, but that as the disease goes further, the family knows and the patient does not know. That is, the anosognosia, or the unawareness, becomes more pronounced. A man named Ryman, Eric Ryman, did a very interesting study in Phoenix a number of years ago. He took individuals that were genetically predisposed, they were at risk, I should say, for developing a dementing condition, and he was interested in knowing whether or not, using PET study, there was less metabolic activity in regions that we know get compromised in dementia of the Alzheimer's type. And he found, lo and behold, in these asymptomatic people, they were not complaining of any memory problems, and performed normal on neuropsych tests. He showed that they had parietal and temporal hypometabolic activity. That was well known by neurologists for many years. When they did autopsy, it was always parietal and temporal that was most affected. But what he did not know, and subsequently became very interesting, is the posterior cingulate. Posterior cingulate was hypometabolic. That was a real surprise. And a number of studies have pointed out this posterior cingulate has a lot to do with the perception of emotional states. And we had a lady who was the daughter of a psychologist who was in the early stages of dementia and gave us the classic statements about, I'm fine. We gave her the test. She did poorly. She explained them away. You got nice tests, but I'm not interested in those kinds of tests. So she just discounted it totally. We put her in the scanner, and we superimposed in turquoise what her metabolic activity was in the early stages, and it matched perfectly. What I want to point out by this is that in different disease states, different areas of the brain may underline anosognosia. Here, you're not seeing any frontal involvement to speak of. It is parietal and temporal and the anterior cingulate. Solomon did a very interesting study with a number of investigators throughout Britain, took over 200 patients that had Alzheimer's disease in the mild to moderate stages so that he could test them. And again, to make a long story short, he tried to, first of all, behaviorally predict what was impaired self-awareness when the individual made comments of just that for themselves. That is, if I asked you, Yehuda, do you have problems with your memory? And let's say Yehuda has problems, and I tried to look at 500 Yehudas or 200 Yehudas and look at the variables that predicted accuracy of the degree to which he had memory problems. He found actually a very modest correlation for 200 people, 0.25. And in here, depression did play a role, but measures that we think have to do with frontal activity like semantic fluency and so forth was a part of this regression equation, but accounted for very little. And then when you do the method that we've used, we ask the patient what's wrong, and then we ask the family member what's wrong. When he did a regression analysis like that, again, he's only accounting an R-square of 0.3, very small. We don't have good behavioral markers of this impaired awareness. But what was interesting is that when he had the person do the self-reflection task, and he looked at collective PET studies, it was frontal and temporal. And Sterling Johnson and I and others have shown that when you're doing any kind of self-reflective task, the frontal areas, particularly the mesial frontal, is in fact activated. But when he did the comparison, when he said to the Alzheimer patient, how much problem do you have with memory? And they had to make a rating, and the family then said, how much problem do you have with memory? Now he sees the correlates of the actual disease state. So they make a very important point that how you measure the anosognosia will greatly influence what are the neuroimaging correlates of the anosognosia, and it will vary in disease states. Now, again, I'm highly attentive to the time, and I'm going to skip ahead. One issue that came up early in the research was whether depression was a protective, whether patients who were anosognosia were not depressed, and that was an argument that it was somehow related to their emotional state. Sergio Starkenstein did one of the first studies that put that one to rest, that anosognostic patients had equal measures on classic measures, equal level of depression on classic measures of depression. So you could not explain the failure, you cannot explain the presence of anosognosia with an absence of depression. Again, there's a lot of misunderstanding about that in the literature. I've told you about Berthe's work this morning. Somatoparaphrenia is a very interesting phenomenon, and I'll just mention two things about it before going to the heart of what I'm going to say, and that's the process and outcome. The patient that I talked about this morning, when she when she had her stroke, she was totally unaware of this arm being affected and was so for almost 30 days. And I mentioned that she was cortically blind, but was aware of her blindness, but not immediately. When we talked with her sister in some detail, her sister told us that within about the first 5 or 10 minutes of her second stroke, she never complained about not being able to see. Only as time went on, she said, I can't see. This lady, as her anosognosia for hemiplegia existed first, but as the disease went on, she started to say, Lefty here has got a mind of his own. Lefty won't do what I'm wanting to do. It feels like somebody else's hand is in my hand. Imagine that. I mean, think of your own hand. What would that be like to imagine that somebody else's hand is in your hand? I mean, it seems psychotic, but that's what the experience is. And we said, whose hand could it be? And they always go for the external explanation. Well, maybe it's my sister's, because she's the one in the room. This somatoparaphrenia has really been shown. There's growing evidence by Vuillemer in Geneva and by Karnath in Germany to have a lot to do with the insular cortex. And patients who show the somatophrenia have a very high incidence of insular cortex involvement. And Bud Craig, who is a neuroanatomist at our Institute at Barrows, unbeknown to me, to start doing this work, has spent a lifetime studying temperature and heat and cold changes. And with animal models, he was showing over and over again, it was the projection from thalamus to insular cortex that allowed for these subjective feelings. So we're now being able to put the puzzle together a little bit. We're able to see that when somatophrenia is present with anosognosia for hemiplegia, often the insular cortex is involved. And As I mentioned earlier, these are the statistics that are appreciated with this condition. People argue about what is the incidence of anosognosia for hemiplegia. It probably is about 20 to 25%. It depends on whether you include complete hemiparesis or hemiplegia versus paresis. It's often associated with neglect. The areas that are involved, frontal, parietal, and insular, but nobody has agreed on the exact mechanism of this. I'm not going to talk about stroke other than talking about two important studies as it relates to the mechanism in children. With the help of a ophthalmologist, we also wrote a recent chapter on anosognosia, a recent update on Anton syndrome, because we could not find any in the literature. And there are many case studies that are reported. One of the more interesting case studies is a woman who had a ruptured aneurysm in the left posterior cerebral artery, and she was completely unaware of her blindness, and the lesion was only on one side. And they said, argument against Anton. They did a PET study, and they showed bilateral hyperperfusion. So even the lesion is on one side, both sides are actually affected. And then I mentioned the children. I was very surprised and happy to find, not for the children, but for our own work as we start to work with children, that in fact they have identified Anton syndrome in children. What's interesting is that this syndrome can be reversible. There are some women after giving birth will have disruption of blood flow in the posterior communicating arteries. I was not aware of this until doing this literature search. And there have been women right after delivery of their baby, they have these hemorrhages, they are blind, they do not know they're blind, it then improves and they're able to see. And there was one 13-year-old boy who had bilateral large epidural hematomas. They evacuated him, and he said, I could see fine. He was completely cortically blind, and it returned back to normal. So there may be an important window here of recovery. And we're going to skip through all of that. Although I want to tell you, I do ask patients about their dreams, with or without anosognosia. And the reason I do it is I want to know, is there some sense that something is wrong? I'm too tempted to tell you this, so I'm going to tell you this story briefly. I have a second home in California, and about 2 years ago, I got a call from my neighbor that one of the water lines in the front of my driveway had broken, and there was water all over the place. I was real calm about it. I said, really, Don, where is it? Tell me. Okay, I'll call the waterworks, and I got the guy. It was over a Thanksgiving weekend. I got the guy in the waterworks. You need to send people out. Understand my front yard is underwater. And I called another friend, and I said, we need to get a plumber out there. He says, I'll go out there immediately. I was very calm throughout the whole thing. I was surprised I was so calm, because this is a house that I love, and the damage to it was really bothering me. But I blocked it out of my mind. That night I went to bed, had a dream, and my dream was I'm walking up my driveway and have this huge tidal wave of water coming over my driveway, and I run up to the door, and I open the door, and my house is flooded, and I'm thinking, oh, what is this going to cost to get everything repaired? The point is, in my conscious everyday life, I had one reaction. I went to bed, I had another reaction that came through. That's not random. Okay, I had an emotional reaction that was not coming to consciousness. So I ask our anosognostic patients all of the time about their dreams. And what comes out is often a sense of, this one lady, she had a dream where she was on a boat, and there was a sick bay on the boat. That is a place where they took care of passengers that were sick. And she was helping people get there. In other words, she doesn't say, I'm sick, but she's helping other people who are in, and she knew she was in a hospital, and she knew she needed help, but she did not have any anosognosia. There was no signs of anxiety over a motor limitation or a motor impairment. So I find that another interesting sort of evidence to see to what degree are they aware or not aware. This is a picture of all of us in 1988. Barbara already showed you a few pictures where I had hair, and there's another one. Ed Weinstein is behind me. Ken Heidelman is to my far left, Don Stuss. Eduardo Biziak, I don't know if I have my pointer here. Eduardo is truly one of the greats in this field. He's over here next to Don Stuss. He subsequently retired, which is a huge loss for the field because he was truly a great theorist. Right behind Ken Heidelman is Dan Schachter, Al Kazniak, and so forth. here we are some 20 years later, and we've changed a little bit. Ken Heilman is sitting next to me. Dan Trinell is to my immediate left. I won't go through all of them. Boom Mayer is in the back, a very creative researcher. Ian Robinson was there, and next to him, Karnath, a very creative guy. To the very far end is Sergio Starkenstein. If you don't know Sergio, you've missed out in life. He's one of the funniest men I've ever met in my life. He's a very creative, funny guy. And then Sterling Johnson is back here, behind the lady with the long red hair. He's truly, you'll hear a lot about his work over the years. He's a very competent, capable guy. Now, I promised Barbara I would stop by 1:15. So I'm going to talk now a little bit about data concerning the process and outcome and what data we have. Yeah, is it here? Ah, it's here. Thank you. This is an old study, but it's an interesting study. Peterson did this in Copenhagen, and he was not interested in anosognosia. I should say, hey, I don't know if it's a he or she. I think it's a he. Looked at over 500 patients treated in Denmark, and they found 21% of patients anosognostic on admission. What was interesting is that two things were interesting. One was, even though the anosognosia disappeared, they were more impaired at discharge. They had a greater likelihood of dying, probably because these are large lesions that produce anosognosia. And even though they were completely free of anosognosia at discharge, their ultimate level of independence was much lower than patients that were not initially anosognostic. Professor Vilke also did a very interesting study where he took only right hemisphere stroke patients who were anosognostic. He followed them at various time intervals. He noted that by 12 months, none of the 49 patients who were initially anosognostic were unaware of their hemiparesis, but he also noted that they had much poorer functional recovery 1 year after. So this was in the stroke literature. I don't know of any other papers that have emerged recently. Maybe there are, but clinicians will tell you, those who have anosognosia for hemiplegia earlier, they make a worse outcome than not. Now, Mark Shearer has been interested in this problem of impaired self-awareness in TBI and has done some very interesting papers. And one of his papers was to look at patients acutely, measure their lack of awareness as they were emerging from period of post-traumatic amnesia. He was interested in predicting employability at time of discharge. And he noted that they could account for 25% of the variability, only 25%, but again, it's during the acute stage. But measures of impaired awareness were one of the key variables that accounted for whether or not the individual was employable. In a later paper, this is one that I thought was clinically interesting, I should say a paper, this was the earlier paper. They had a model that was based on Dr. Ben Yishai's program as well. They worked with patients that had mainly brain tumors, but not limited to that. And they were trying to predict who would go back to work. And they had, first of all, what they called their 5-factor model. I don't think there's a neuropsychologist in the group who would disagree that the variables that he identified most likely relate to who goes back to work. Severity of injury was one, chronicity of injury was another, pre-employment history was another, the degree to which they used alcohol prior to the injury was another, and the level, I can't remember what LFC stands for now, sorry. In any event, he looked at these variables, and you can see with a regression analysis, it really accounts for a very small percentage of the variance. They then had clinician ratings of awareness. They added to this variable, and it improved it a little bit, 0.29. Then they used the method that we have used, the patient versus the family. Again, the statistic was almost the same, although the level of significance was higher, but I think that's really not all that important. They put all the variables together and accounted for about 0.41% of the variability. But then they subtracted the awareness. They left the two awareness measures in and it accounted for about 1/3 of the variability. What's the point? The point is that measures of impaired awareness, however you cut the cake, does relate to an important part of the variability for who goes back to work versus who does not. A paper that came from Montreal looked at whether or not awareness of deficit impacted treatment adherence, that is, whether or not you would do what the therapist asked you to do. These were acute patients, and they again used a comparison of patient versus clinician ratings, and they studied spinal cord patients in relationship to the TBI to see if it was unique to a brain disorder versus to a spinal injury. And they replicated our previous findings that the TBI patients were not unaware of everything. They tended to minimize certain cognitive and affective difficulties. The poor awareness was related to treatment compliance, that is, whether or not they followed the guidance of the therapist. And interestingly, the awareness of the emotional and behavioral problems was at the same level of correlation as the awareness of the cognitive problems. They did not find any such relationship in spinal cord injury patients. We've done 2 studies trying to look at who goes back to work in the relationship of the treatment alliance. And all I'm going to tell you is that we found a relationship and we continue to find a relationship. And the reason I'm going to tell you that without going through all the data is that our colleagues in Copenhagen have picked up on this, and we're interested in looking at treatment alliance. They use the word working alliance, and compliance as well as outcome. In this one paper, they show that the working alliance with the with the neuropsychologist did relate to work status of the individual. They then later did an interesting study, and this one has really made me think about the question that was asked earlier about what can you do to help these patients. They had a mixed group of patients now. They had patients that had stroke as well as TBI and other injuries, so it's a heterogeneous group. And they point out, what others have pointed out, that the awareness was related to the good working relationship and so forth. But what they noticed was awareness did not seem to change during the rehabilitation process. I've asked my friend Pam Klonoff whether or not she agrees with this. She doesn't agree with it. I've said, Pam, then do the study to show that you can change awareness with the passage of time. It is not so easy to show this, and I'm going to skip ahead because of the time. And I'm going to come back to this in a little bit because I really do want to touch on an important finding that relates to this. There was an interesting paper. Yeah. Please forgive going through so many slides so quickly. This one. You may be familiar with this paper by Owensworth, I believe. It's Owensworth from England, from Australia. I like this study on a number of reasons, but I'm going to walk through the study as I understood it and what important point it raises for me as a clinician. These investigators asked the question, can you improve awareness via metacognitive training in a post-acute traumatic brain injury patient? The person was 36 years of age, had suffered a severe traumatic brain injury, and had persistent impairment of awareness for in excess of 4 years. They worked with him on a 16-week intervention program to teach him error awareness in performing a cooking task. Now, I have a little concern about whether this is long enough, 16 weeks, but that being as it is, they did something that I think was very important. They got a task that the patient was interested in. The patient liked to cook. So they gave this person a task that would engage them, would hold their interest. They then used a model that they talked about where they would have the patient pause or stop. They would give them a prompt to scan what they were doing. If they detected the error, they praised them. Okay, so they used a little behavioral manipulation. They showed that they could improve the detection of errors, and this was of help in making less cooking errors, but they did not substantially influence the level of awareness of the patient. Let's just go over this again. It's important. You can train the patient to be more vigilant. You can train them to be more vigilant. But when you ask them about their level of difficulty, their level of disability, it doesn't necessarily improve. That's a really important observation in my mind. It goes back to how this is such a complicated function. It must integrate multiple areas. And I think this is why I have favored a more psychotherapeutic approach embedded in the model of Dr. Ben-Yeshai's. I fully agree you need cognitive remediation tasks. I fully agree you need individual and group work. I fully agree that you need a coach or somebody that will work with that patient acutely. I fully agree you need families engaged in the rehabilitation process. I fully agree that you must educate those families. But where I really emphasize is if you do not know what the patient experiences, if you do not know their individual personal reactions to their brain injury, you cannot be as effective. And that's why psychotherapy is so important in the rehabilitation of these individuals. Because psychotherapy, as we'll talk about tomorrow, is really an individual facing the truth in their life and looking at the complexities of their life in the context of a relationship that is protective with somebody who knows what they're looking at, that understands the complexity of what they're looking at. And that means understanding the childhood development. It means understanding who they were right before the injury and so forth. Now, Barbara, I'm going to promise, I'm going to end here in 4 minutes. Go, maybe 10 minutes, okay. Sterling Johnson and I suggested in working with traumatic brain injury, there really are 3 overlapping types of consciousness that can be identified. And this was based on early work by Zeman, a neurologist in Great Britain, who wrote a paper on consciousness that I really like. It doesn't apply to all forms of anosognosia. I'm not sure it applies, for example, to anosognosia following stroke, but the model is very helpful for traumatic brain injury and for rehabilitation. He says, when we use the word consciousness, we use it in 3 ways. One example was, he said, the soldier regained consciousness after being injured. That's the sleep-wake cycle, okay, so to speak. We're unresponsive to the environment. The second type of consciousness is, I'm aware that I tend to get tired at this time of day when I travel, okay? It's a subjective phenomenological state. I can also have a type of consciousness where I'm aware, hopefully, of your needs as well, and that I have to be cognizant that other people need to speak here, so I can't just keep going on. So it's an awareness that has to do with sleep-wake cycle, what's real, which is not real, awareness of me in the here and now, and the awareness of you. And I think if we think of awareness in these 3 overlapping ways, it provides some interesting ideas about how to rehabilitate patients. The vector 1 consciousness, I wish I had more time to explain, but the upper brainstem, the thalamus, and portions of the hypothalamus are very active. When we're dreaming, these areas are highly activated, and frontal and parietal activities are less activated. It's very interesting. They're less activated. Now I am going to go back and show you something. Whoops. Because when we did, okay, when Sterling did this study that got us thinking along these lines, we had normals go into a scanner and simply reflect on characteristics about themselves. Well-designed study, all accomplished by Sterling. We had the patient in a scanner with 2 buttons, and we'd ask the patient, do you have many friends? Yes or no. Are you easygoing? Yes or no. Do you tend to get irritable quickly? Yes or no. Then we ask questions like, what direction is Washington's face when on a quarter, an American quarter? Is he turning to the left or is he turning to the right? So both required reflection. Some had to do with reflection of the self, other had to do with reflection of the outer world. In each subject, there was activation in the mesial prefrontal cortex, and in that posterior cingulate. Varying degrees, not everybody with the same amount. The reason I point this out is that these areas are hypometabolic when you dream. The same areas that activate when you are awake and you're reflecting on yourself are the same areas that are hypoactive when you are dreaming. Very interesting observation. We believe, and other people have talked about this, that this first type of awareness that involves deep brain structures may have something to do with denial. It goes to the psychiatry of it. There is suggestive, partial, limited, flawed data that suggests that in denial phenomena, the basal ganglia and the basal ganglia and the thalamus and parts of the basal ganglia and the thalamus are less activated. A very interesting paper by Volumer several years ago showed in individuals with hemisensory loss that was thought to be hysterical in nature, using a stimulation design, showed that it was the deep brain structures, the thalamus and areas of the caudate, that were most suppressed during the denial. After they were treated with pharmacology and psychotherapy, the activation in those areas increased. There are other studies that point to the same thing, where denial may have more to do with the deep brain structure monitoring problem, if you would, and unawareness may have more to do with cortical. That's a terribly brief, oversimplified statement, and I wish I had time to develop the ideas. But if you go to rehab, you ask me, how can you take some of these ideas and apply it to rehabilitation? When patients have had injuries that affect the first vector, the alertness, the awareness, we do a lot to increase arousal. Dr. Benyushe's technique, what's the name of the time? It's cognitive group. What's the purpose of cognitive group? Is to learn to process information faster. Why do we do, what's the value of that? You are alerting the patient. You are raising the arousal level of the patient. Anytime you increase arousal level, you do have a greater chance of improving self-monitoring. So when there are disturbances to that level of consciousness, medications, physical therapy, getting the patient up, moving the arm and the leg, anything that increases the arousal level will help them. We're starting to experiment with some traumatic brain injured patients, and we're putting them on a treadmill. And we have their hands on the treadmill as they're walking. And they start off looking at what the heartbeat is, 66 beats, 67 beats. Then we have them walk at faster rates of speed and predict what the heart rate is before they put their hands on it. It's a simple biofeedback technique. We want to see if we can start off with awareness of internal physiological states as a way to build the first building block to the awareness. And we're just beginning this with some patients. Whether it will work or not, I don't know. But we think there's good reason to believe that the insular cortex, which is probably the basis of all subjective feeling states that have a lot to do with perception of heart rate, temperature, and so forth, if you can make finer and finer discriminations regarding one's physiological state, that may help improve awareness on the first vector. The second vector has to do with the phenomenological state. And there is nothing new under the sun here. Here is where we have patients do a task, they observe how they do, they observe how other people do. The group work is very helpful in this regard. It is comparing my reality to your reality. Some patients respond to this type of feedback, some do not. Some discount it. I suspect many of them discount it have to do with the denial component. But we spend a fair amount of our cognitive group work not just trying to teach them to be more vigilant as it relates to attention, not only teach them memory compensation, but to be aware of the degree of problem they have in these areas. The third vector of consciousness has to do with the subjective perception of your state of life. And again, there is nothing new in this area per se, but in group psychotherapy, where relationships are formed, we find that people are able to better perceive, better understand someone else's emotional state, and as a first step to becoming more aware of not only that other person's emotional state, but what they're actually thinking, what their needs are, and so forth. When I have a patient that has primarily severe unawareness, I very seldom focus on awareness at first. I focus on what I said earlier. I focus on trying to figure out how to reduce their confusion and help them become less frustrated. In the context of that, I build a therapeutic alliance. I can tell you one patient I saw years ago, very unaware, but his room was noisy and the food wasn't very good. And all I did was talk to the nursing staff about, let's not wake him up in the middle of the night, let's let him give a good night's sleep, and let's see if we can put him in a room towards the end of the hall where it's less noisy. I just tried to take care of his comfort level. We formed a bond. He was totally unaware of what his difficulties were. But when I said to him, and I put my hand on his shoulder, let's not get so hot right now, he would calm down. If I was a stranger and put my hand on his shoulder, he'd smack me. So with early, it's simply build the relationship. Make them more comfortable, reduce their confusion. As they progress and they have partial awareness, then you're constantly struggling with what role does defensive mechanisms play in how they cope with the problem. And this takes a long time to learn. One of the big problems is that rehab, you've got 26 days to do it. I've never heard them tell a neurosurgeon, you've got 8 hours to do this surgery, because they know what they're doing, and the outcome is good. When we really get good at rehab, we'll be able to tell you how much time we need for a given patient. I've never seen any study that can predict accurately how much time is needed to get patients where they need to be. Not one. In the course of working with these patients, it does take a long time, but then as you get to know them, they will now tell you things that are important in their life. How many of you, when you first meet somebody, unless you're intoxicated, tell them really personal things about yourself? You don't. It's too personal, it's too private. Only when you form a relationship with them will you begin to tell them the truth. And I've had patients not tell me the truth until a year into psychotherapy. They've paid the bill each week, but they won't tell me what's bothering them for a year. In brain injury rehabilitation, as we build the relationship, they'll tell you what's bothering them. And with that, you then can work with why does the denial, why is it there? Is there another way of coping with the denial? And that's why I'm a firm believer that psychotherapy is a crucial component of brain injury rehabilitation. There are some patients who have very minimal or no awareness that have denial. They are the most difficult. And these are the ones that have the alcohol addictions or the drug addictions. They may have no brain disorder at all as we know it, but they are highly defended against any reason of why they should stop taking cocaine, why they should stop drinking. One patient said to me, my best friend is Bud, meaning Bud Light, okay? And he wrote poems about Bud and why Bud was his best friend. And he wrote poems about when he had Bud, he could be more open and more capable of persuading people and so forth. When he started to write the poetry of why Bud was his best friend, he started to stop drinking. When the inner problem is made exterior, it points to the next step of psychological development. Many books are written for this purpose. When I can put in what's in me on paper, or if I can draw a picture, or if I can write a song, many of the powerful songs that are written, that has to do with the psychological struggle of the artist. Once that's made exterior, they now know what's the next step in their life. The same is true in working with patients that have traumatic brain injury. When you can understand what is driving the lack of awareness or the refusal to admit, then you move forward. So I will stop. I appreciate your time, and I hope these very brief comments, again, have some help. For those of you who will be at the workshop tomorrow, we'll try to talk in a little bit more detail about how psychotherapy does or does not help in certain cases and why that seems to be the case. I'll take 5 minutes for any questions, and then Dr. Wilson will take over. Any questions? You want to stand up and stretch? You want to continue to sit? Barbara needs 5 minutes. Okay. Well, Barbara's getting 5 minutes. If you don't have any questions of me, I'll ask you a few questions. Tell me what you're going to face Monday morning with your patients who are unaware. Describe to us what it is that you've experienced.
I can tell you what I experienced last week, and I can take you forward.
Okay.
First, after your psych assessment and a better understanding of the problem, there's this patient today, he has this car accident, and he would deny that there is something wrong with him after the accident. Of course, he doesn't remember the accident, of course, he doesn't He said no. And he was able to say that there was also this video clip showing him people having car accidents. That, oh, that must hurt, or this must have affected him probably the way he walks, the way he thinks, etc. But obviously, he said there's nothing wrong to me because I walk, because I speak, because I understand what's going on around me. So this is where we are.
Yeah, okay. So he can intellectually see if there may be a relationship between injury to the brain, but some objective problem. Since he doesn't have that obviously objective problem of walking,
Yeah.
he doesn't make the connection.
Because he's being reinforced from his
Okay.
behavior.
The question that then naturally comes up is, do you have any trouble with memory? Do you have any trouble with speed of doing things? What does he say?
Actually, I did what you said before, the video test of asking the patient which areas that you have problems or not before and after the accident. So his answers were all of them and the same as before. Which is also in contrast with his family's answers, that they say that there are differences in memory, etc. So he doesn't accept any deficits in either area. He
Okay.
thinks it's exactly the same.
Again, the technique that Dr. Benisha taught us. Is he slow in processing information?
He is, but yes.
Okay, so you sit down with him and you say, I'm going to write my name, George Prigatano, and I'm going to have you time me. How long does it take to write George Prigatano? Okay, let's say it takes 10 seconds.
Yeah.
His name is whatever, but let's say it's a shorter name,
Yeah.
and he writes it in 35 seconds. You look at that. Why is there a difference?
I really have his answer because
Okay.
we sort of tried it. He used to exercise a lot before, and now he's lost, but he doesn't anymore. Now, when I asked him about his slowness, because he might agree that he is slow in moving compared to before, but if you ask him why, then he says that this is because he doesn't exercise anymore, so his muscles are not as strong. So he has the explanation.
Okay, yes? They always will. There'll always be an explanation. But the value of the group work is that he can observe not only his behavior and your ability, but how other people are doing the same things. And it's in the context of that that you don't know when it will happen, but suddenly, not suddenly, occasionally, they'll look up and say, I'm a lot slower than I thought I was. I'll give you an example that came in Oklahoma City. We had a dancer that was always, she was from China, and she had a number of injuries, orthopedic as well as brain, and they always try to have her weight bear, to get her posture better. And she would always fight because it was painful. And one day, an experienced therapist just tilted her pelvis in a certain position, and she looked at us and says, that's the way I used to stand. Can you imagine? All of us know how we stand, right? But what if you didn't have a conscious representation of what your body posture is or how you weight bear? That one insight